So good afternoon. This is Marina Vivarelli. I'm in Rome in Italy, and it is my great pleasure to introduce Professor Christoph Licht, who is giving a seminar today for an ERKNet combined ESPN webinar. The title is C3 Glomerulopathies, and Professor Christoph Licht is Professor of Pediatrics and also staff physician, pediatric nephrologist at the Division of Pediatric Nephrology of the Hospital for Sick Children in Toronto in Canada. He and his group have contributed very significantly with both basic and applied science to our understanding of complement within kidney diseases, in particular C3 glomerulopathy and atypical HUS. More recently, they have also focused on the role of complement more in general in a variety of different inflammatory conditions and also in neurodegenerative diseases. So we have the pleasure and the privilege of being able to listen today to a true expert who will be able to give us I think, brilliant overview of these diseases. So it's a real pleasure to welcome Christoph, and I'm very, very pleased to have the opportunity to moderate you today. Thank you.
Thank you very much, Marina, for this very, very kind introduction, and thank you to the organizers for the invitation and the opportunity to presenting to this at this fantastic forum. What I'm trying to do within the next hour, with hopefully a lot of space for Q&A at the end, is to introduce MPGN coming from the traditional classification, introduce the new classification, how we think about it today, think with you through the lessons that we have learned from mice, animal models, and patients in terms of pathogenesis, translate all of that into diagnostic, therapeutic, and kind of our thinking about outcome approaches, and then sum it all up. If you want to really go back into the beginnings of the background of MPGN, then you end up with a different term. It's Bright's disease, die Brightsche Nierenkrankheit. As a German, I can pronounce that. And it was introduced into literature actually by Volhard and Farr in 1914. And I just skip to the next slide to show you the drawing from this original publication. That is not a picture, that's not a histology slide, but it's a drawing from this early publication that already has many of the features that we today still think are identifying the MPGN kind of signature, histologically spoken, captured in a fantastic way, and we'll come to that in a moment in more detail. It was then in the 60s, at the first international renal biopsy meeting, that MPGN was first defined by a variety, or the combination of a variety of findings made in patients with Bright's disease. And at that time, MPGN became a formally named subtype of GN, a disease in its own right. And at the same, around the same time, then people associated with this histological finding, a clinical signature with an early disease onset in pediatric age, and the lead symptoms of proteinuria up to nephrotic range, hematuria, and decrease in kidney function. It was already in the 60s of the last century that Clark West, just to pay a tribute to him, I show his picture here, and I had the pleasure to meet him once, that he introduced into the literature the concept of a role for complement in MPGN when he described hypercomplementemia in MPGN, and suspected at that time that the classical pathway was involved. Moving forward from these days, pathologists worked hard to define this membranoproliferative pattern that, unlike macroscopy, is defined by mesangial expansion, hypercellularity both in the mesangial space and endocapillary, the swelling of the expansion of the basement membranes with immune complex depositions, mesangial interpositioning, and in the end of the day, double contouring or the tram-track appearance of this swollen basement membrane. On immunofluorescence, complement C3 and immunoglobulins, in particular IgG, can be found. And then on electron microscopy, dense deposits in various areas, both in the mesangial region and then in various spaces around the basement membrane, both subendothelially and subepithelially, were described to altogether define this membranoproliferative pattern. Subsequently, again, further subtypes were defined depending on where those dense deposits on electron microscopy were identified. The type 1 when it was in the subendothelial space, the type 2 when it was in the intramembranous space, and the type 3 when it was on both sides of the basement membrane. So a first question for you. What of the following is included in the histological findings in MPGN? An easy one to start. And just for Marina, I can see the question, but I don't seem to see the responses. Oh no, I see it actually. Perfect. 90% of you clicked all of the above, which is exactly what I had just spoken to you about. Thank you. All right, let's continue. So now while effort has been made to describe the histological lesion, of course, people try to understand what was it caused by. And one observation was that it is in its secondary form linked to, or its affiliated form linked to an underlying or concomitant condition. Which of the following is not a cause for secondary MPGN? Perfect. Almost 90% said cystic fibrosis, which is the correct answer. And on this slide here, and I will not spend too much time in the rest during the rest of the talk talking about the secondary forms, which make up a large proportion. As you can see, this is a table that kind of summarizes what the literature identifies as underlying conditions to be linked or affiliated with this membranoproliferative pattern. So it begins with and is really driven by infections, and there hepatitis B and C in particular are lead diagnosis. There can be underlying systemic immune diseases. MPGN pattern can occur in context of malignant diseases, chronic liver disease, or there is even this miscellaneous group where we don't have C3 or IgG, but still histologically spoken, this membranoproliferative pattern, and diagnosis there include TMA. It can be can be present along with an ATTR or a TTP presentation. It can be present in radiation, antiphospholipid syndrome, sickle cell disease, or transplant glomerulopathy. So keep those in mind, and you will find those tables in various forms in review articles. The story has moved on to what we call now the new classification. And it really was triggered by a seminal publication by the French group lead author here, Servet, who appreciated that complement defects really in a spectrum fashion are involved not only in HUS, thrombotic microangiopathies, but also in C3G, or rather in MPGN at that time, and that both conditions could share defects in the same system, which is the alternative pathway of complement. The difference between the two conditions was that on the TMA side, complement dysregulation was more towards the endothelium, so it was more local, versus in the MPGN situation, it was more systemic complement dysregulation. That's what I just said. And so we moved from what was the historical classification with these 3 types of MPGN and according electron microscopy findings to a classification that was appreciating that we had a subgroup of patients, a core group of patients in whom the appearance of C3 on immunofluorescence was really a lead feature. And those were kind of singled out as the so-called C3 glomerulopathies. And besides those, the conditions were C3 and various amounts of IgG or IgM or even C1q were identified, were separated from that. And with that, we moved to the modern categories of C3 glomerulopathy or C3G, and separate from that immune globulin or immune complex mediated MPGN. Histologically, these C3 dominant forms were really identified on light microscopy by a C3 staining that was more than 2 magnitudes stronger than any other staining, including IgM, IgA, IgG, and C1q. But it is important to notice that it is not an exclusive light microscopy diagnosis. So it's not a yes-no finding, but you can find C3 or C3 split products and IgG being positive on light microscopy. It is the magnitude difference that makes the case. To make things more interesting, more recently, after having established now these new categories, the pathological findings in patients in whom more than 1 biopsy was done pointed to the fact that yes, those categories apply, but if you biopsy patients more than once, especially when you biopsy them in the acute phase and then in the sub or post-acute phase, then these categories or these classifications in a specific patient can change. So what I'm showing you here is the light microscopy, the IF of a child that on the staining that I'm presenting here has some IgG but strong C3 staining, and the diagnosis at that point was, in keeping with what I've just introduced to you, immune complex MPGN, IgM, and C1q were close to background. 10 months later on biopsy, the IgG staining was gone, and this patient had almost exclusively signal for C3. So now the diagnosis is C3GN. Since on electron microscopy, the patient did not have any intramembranous deposits. Another case, basically the same finding, focus on the immunofluorescence, IgG, strongly positive together with C3 on the first biopsy 6 months later, the IgG was gone. I'm not showing it here. And this mixed picture of mesangial and standing along the basement membrane of 4C3 was left, and the patient was reclassified as C3GN. So again, the categories that were introduced with the link to the underlying pathology are valid and very, very important, but it's not a static diagnosis. Patients seem to move through those through various stages throughout the course of their disease. Now, as you appreciate, this new classification, and I've hinted this a couple times, really changed our approach from being strictly based on morphology, histopathology, to findings that have implication in terms of the understanding of the pathomechanism or the pathogenesis of this disease. And now I would like to ask you first a question. So which of the complement pathway, and this is basically where we're trending towards the story of complement dysregulation, which of these pathways is mainly involved in the pathogenesis of MPGN? All right. I'm happy that 28% said classical pathway, 66% said what I was kind of trying to get to, the alternative pathway. But you're absolutely right. There is evidence that we are dealing with probably also an involvement of the classical pathway. In particular, the presence of those immune complexes, would make it very likely that the classical pathway is involved. The few ones who clicked terminal pathway, I assume that those ones were might have thought about possible reports of treatment success with terminal pathway blockers like eculizumab in those patients, and we'll come to that in a little bit too. So this is not completely out of context either. Okay. Now, very briefly, what do we have in terms of scientific insights into a link between the complement system and pathogenesis of MPGN? And I apologize that as the literature myself, I cannot be clean with the nomenclature that I'm using, so I will switch and jump a little bit back and forth, and there is no real intention. I will highlight if it is important to be precise with the specific diagnosis that I'm talking about. So for the sake of being simple here, I'm talking about MPGN. There's some literature on naturally occurring factor H deficient pig strain, and those animals died from renal failure, and on electron microscopy of their renal biopsy showed basically very strong deposition of C3 and C5b9 in their basement membrane, and showed on plain EM this swollen basement membrane at the top left, as opposed to the control at the bottom right. So this picture really appeared like dense deposit disease, and that was where the first link systematically in an animal model was established between complement and the pathogenesis of a C3G. A few years later, the defect underlying was identified. It was a truncating mutation in factor H, The protein was expressed in liver cells that you can see here, and the GFP labeled factor H on the right side was not able to be released from those cells, so the periphery was basically depleted of factor H. Years later, Matthew Pickering resembled the genetic situation, or repeated the genetic situation in a genetically engineered mouse model, factor H knockout mouse, which was not exactly presenting with a dense deposit disease phenotype, but with something that is more a C3GN, like a subendothelial expansion or situation with deposits, as you can see here, with C3 deposition and C9 deposition along the basement membrane on the endothelial side. And he kind of took this story one step further and created a double knockout mouse where he removed factor B from the system as well, along with factor H. And with that, he basically blocked the alternative pathway and rescued the phenotype, and with that not only confirmed the role for complement, but also identified the alternative pathway as a key driver of it. Just to put it into a systematic cartoon, the complement system, since we continue to talk about it now, with the three initiating pathways, classical, lectin, and alternative, merging together in the amplification loop of C3, which can be amplified either through the alternative pathway convertase or the classical pathway convertase, leading to the initiation of the terminal pathway through the respective convertases for C5 and the formation of the end product of the terminal pathway, the membrane attack complex C5b9. To understand the role of complement in MPGN or C3G, it might be helpful to look a bit more into this central step of C3 activation. I just mentioned it. C3 is amplified via the C3 convertase, and this here is the alternative pathway C3 convertase, and there is under physiological conditions a balance between activation and deactivation or inhibition rather in place to keep the system basically alert, but control it and prevent it from being overactive in situations when it's not needed. Activated C3b is cleaved by concerted action of proteases and cofactors to become inactivated and then be further metabolized into split products. If that is not happening, then the terminal pathway is initiated and the terminal pathway product C5b9 is formed. Our simple thinking about the two major diseases where complement is today established as a mechanism, as a major component in its pathogenesis, APPHS and now C3G, is summarized on this cartoon. So in atypical-HUS, as I mentioned earlier already, this pathway runs in overdrive towards the terminal pathway and the membrane attack complex that injures the endothelial cells. Different from that in C3G, we today think that it is a question of loss of control of C3 activation. And if you lose control here, you generate a lot of C3b, and with that a lot of split products, and those split products then are felt to be the drivers for the pathology in the kidneys. And this is nicely It's the last animal study slide that I'm showing you. And this is nicely captured by a study, again, by Matthew Pickering, where they generated a factor H, factor I double knockout mouse. The intention of this study was to enhance the phenotype of the factor H knockout mouse. What they found in the first place was a mouse with almost no renal phenotype. And even normal C3 levels. Only when they injected serum that contained factor I, so there is restored some of the factor I, C3 was metabolized, which you can see here on the Western blot. After injection, C3 split products appeared as a result of C3b digestion, at that time, the glomerulopathology appeared. So what you needed was really a generation of those C3 split products to find a C3G phenotype in at least in light microscopy here in these animals. And with that, we have basically this pathogenetic concept for C3G for the primary form, where we assume that the C3 convertase is in overdrive to generate split products in abundance that are non-physiological, superphysiological, which then are the driver for glomerulopathology. And we will talk in the next little while about the causes for this dysregulation situation. I'll do this very quickly. Sanchez-Setti contributed in 2 studies published in 2009 and 2017. Basically, findings, the first paper at least was in dense deposit disease patients, where he investigated tissue from C3G patients, looking for the protein profile. And he found in his proteomics analysis of this tissue a prevalent score for C3 and other complement products, but C3 was the top score across the board of here 12 patients in the 2017 paper. So basically confirming or adding another argument for a role of complement in the pathogenesis of these C3G patients. Now, what drives this? I showed you the summary slide. I mentioned that it is really about the dysregulation of the C3 activation. What drives that? And we know 2 major conditions. It's either the presence of antibodies or its mutations. This table here shows you the today known antibodies participating in this C3 convertase dysregulation. The one that you most likely know is C3NF, an IgG antibody against the alternative pathway C3 convertase. It's present in all types of C3G and IC-MPGN. It kind of it works as a stabilizer of the convertase complex and makes it with that just overactive. I skipped to C5NF. More recently found is an antibody, also an IgG antibody that can occur alone or together with C3NF, and in the first place stabilizes the C5 convertase. If it's alone present, it mainly shows overactivation of the terminal pathway. If both are present, then the C3 convertase overactivity is the lead finding. A factor B antibody was found in dense deposit disease patients, also stabilizing the convertase complex, which contains a protein factor B. And then there is most recently published anti-C3b antibodies also against a component of the C3 convertase with poor outcomes in those patients carrying these antibodies. Sepomeri already a couple decades ago published this anti-factor H antibody. Don't confuse this with the antibodies known from atypical HUS. Those are in atypical HUS are against the C-terminal end of factor H. These antibodies found in C3G patients, and they're rare, are found bind to this N-terminal end of factor H and basically take away the function of factor H. All of those antibodies, except for the C3nef, are rare and are definitely not yet a part of routine testing. And I apologize, the yes in the last box here is wrong. It should be a no. This type of factor H antibody is not a standard test. The C-terminal end in atypical HS, of course, is a standard test. As I said, the second way to lead to an overactive C3 convertase of the alternative pathway is via mutations. I won't go into much detail here. You see the genes, factor H, I, C3, factor B, and then a couple in whom I'm not 100% sure how to interpret them, to be honest, are described. The third column really highlights the function, and in the end, the consequence, the functional consequence of these mutations is very similar to the consequence of what I've introduced to you on the previous slide with the autoantibodies. It's an over activated situation of the C3 convertase complex, and the factor H mutation, like the factor H antibodies that I just spoke about, carry mutations that basically allow for the factor H to bind, but take away its function, since its mutation in the mainly hitting the N-terminal end of factor H. And you see on the right, most right column, that these mutations are found across the phenotypical spectrum of the C3G diagnosis. When I've introduced the new system to you, then I mentioned the core group C3 identifiable, C3 deposition identifiable and called C3 glomerulopathy, versus the others where we have immune complexes playing a role as well. And we spoke mainly about, the link of this core group of C3 glomerulopathies to defects in the complement system. Now, a very, very important paper published by the Italian group in 2016 did something against this kind of assumption, and basically sequenced all patients. So here they call them IG MPGN, you could also call them IC, immune complex MPGN, and the C3Gs. So these are the ones I've spoken to you about. They sequenced also the rest of their cohort. And what they really found, focus on the genetic analysis paragraph, please, is that they found mutations in both of those groups. And in both of those groups, those mutations affected the alternative pathway. And the additional, so this dogma or this rigid assumption that the mutations are applicable only to the C3G group is wrong. It is applicable across the board. And the second finding here was that they identified risk haplotypes in MCP, CD46, and factor H. And they identified that the combination of risk haplotype plus another mutation really enhanced the manifestation risk in IC or IG MPGN patients, as did the number of susceptibility or risk variants, with the highest number carrying the highest risk in C3G, together with the presence of underlying mutations. So this is really a seminal paper that is highly important, and I recommend it for your to your reading. I might skip these few slides here for time and come to this here. So we have spoken about factor H. We have spoken about autoimmune causes, antibodies causing C3 convertase dysregulation, and we have spoken about antibodies, and we have spoken about mutations. There's a new theme that is maybe so far even still underappreciated, which is the so-called factor H deregulation. So you probably know that, you may know that factor H is encoded on the long arm of chromosome 1q22, and downstream of factor H, the factor H locus, there is a sequence of 5 factor H related similar proteins, which are depicted here, identifying similarities between this family of related proteins and the mother factor H. Now you see that the C-terminal end and the N-terminal end, the 1s and 2s and the 4s and 5s or 8 and 9s, seem to be shared within this group of the factor H related proteins. And this is kind of highlighted here, in particular, identifying similarities between 1, 2, and 5. And what that leads to is that those proteins, so the gene products, form dimers, both homodimers or heterodimers in blood or in the circulation. And the concept is that these dimers, which still share with the yellow kind of bubbles highlighted, a binding similarity with factor H, and with that they compete with factor H. They do this under physiological situations, to fine-tune factor H's function. That's what we think about, since they do have regulatory capacity, but they are not as strong as factor H. So you basically balance the factor H function by having those dimers around. The problem with this gene locus is that the sequences are highly repetitive, and with that prone to form intrallelic or across the alleles recombination events that can lead to either copy number variations in form of deletions, duplications, or chimeric, the formation of chimers. And what you see here at the bottom part is is examples that are published. So this is fusion proteins, for example, where the presence of these repetitive sequences have resulted in breakpoints and then recombination events, and then you get those, as I said, copy number variations. And one of those is, for example, these fusion proteins. And the problem with those fusion proteins is that they, again, do form dimers, but they form them in form not only dimers, but they also form heteromers and multimers, and those complexes are now way more avid to compete with factor H than the physiological homo and heterodimers. And this is shown here. So what we have is basically a factor H related protein locus driven presence of, or we can have it, of mutations leading to pathological forms of those dimers or multimers, competing off the function of factor H. So you have normal factor H, but you lose its function. And that, in addition to the mutations that I've shown you, plus the autoantibodies, is the third form of dysregulation of complement that is linked to C3G phenotypes. As promised, for the last part, let's take this to clinic. Relatively quick, but in one slide summarized, but very important and often enough very difficult to achieve. With all this insight, of course, an in-depth workup of the complement system, including genetic forms, autoimmune forms, the antibodies, and an activation profile would be what we would hope to have at hand to rule in or rule out any of these defects in a given patient. I just updated this slide here by the other nephritic factors that I've shown you, other antibodies, and these additional mutations in the factor H related locus. One last question for you. How do we treat C3G patients? Which of the following is what you think is right? Yeah, that highlights our problem. 68% said it's really case reports and small case series only that we have. If I would have had more characters, I would have added. And on top of that, we have, of course, opinions, expert opinions, hopefully, but still a lack of firm data, which is one of the major challenges in this context. What do we have? We have evidence in the literature that supports the use of immunosuppression. It mainly supports the use of steroids and MMF. And this either in alone or in combination, in particular the MMF. There is a documented benefit for long-term, up to 12 months, low-dose steroid treatments in MPGN C3G patients, and the readouts really in those reports are proteinuria and renal function. And excuse me, the standalone or combination use of MMF plus minus steroids is also documented in the literature, and that includes children. I just wanted to highlight, and this in one trial, this trial here, that's what I wanted to highlight, the 42 out of 97 C3G patients were treated with steroids and MMF. So in this relatively large trial or case report, a case series, those patients had remission of proteinuria and deterioration to prevention to renal failure was prevented, and this was compared to other immunosuppression and eculizumab, and it was regardless of the presence of mutations and or antibodies. Of note, in the last bullet point here, 22 out of 30 C3G patients in another trial treated with the combination of steroids and MMF showing response in 50% demonstrated relapse when MMF was tapered. So the kind of the experience in the literature really led to those KDIGO expert recommendations with the statement that MMF is beneficial in patients with IC-MPGN and C3G, and of course, especially in the beginning, in combination with steroids, and it can be continued as monotherapy up to 1.5 to 2 years, after a steroid taper within the first 6 to 12 months. I'm not shocking you with this table, but with the next couple slides, I will just make the point that given our insights into the role of complement, of course, there is respective or according treatment strategies in place, and that includes plasma treatment with some documented benefit. So there is, of course, there's a publication bias, but there is a number of case reports that report either partial or complete remission. It's limited though. And then there is very limited increasing numbers, but still very limited experience with the use of the one available complement blocker. You remember that we highlighted the role of the C3 convertase, so a more upstream part or step in the complement cascade. And so it's not too surprising that the terminal blocker eculizumab is not really the blockbuster in C3G. Here is probably the three of the key studies that you should hear about. Our host, Marina, has published a case series of 13 patients with C3G and dense deposit disease, both native and transplant kidneys, and various defects in the system, of whom 3/4 responded, and those patients were characterized or stood out by high C5b9 levels and a shorter treatment, a disease duration. A French cohort of 26 patients, half of them children, responded only in about 6 out of them had complete and 6 partial response. And in those patients, the underlying complement defect really didn't make a difference in the outcome. And then there is one formal mini trial with 10 patients, the EAGLE study, in whom 2 blocks of treatment were applied, 48 weeks each of treatment with a 12-week washout in between. And the outcome, the primary outcome, was improvement in proteinuria. And in those patients, this treatment trial was mainly a failure. Interestingly enough, the first half of the trial seemed to have been successful in 7 patients, but the benefit was lost basically during the washout period and then throughout the second period of this trial. So with that, eculizumab in C3G and IC-MPGN is currently only used as a rescue therapy and cannot be recommended as a first-line medication. And the best response seems to be found in patients with recent onset of disease and a strong inflammatory component, including high C5b9 levels. I will just touch on this slide in terms of outcome to leave a little time for questions at least. So there's of course reports, again, no large cohorts, no real robust data, and only very limited data on children. To really sum it up, negative outcome predictors in C3G, and this is pre-targeted treatment, pre-complement targeting treatment, is age at presentation and decreased kidney function, and high proteinuria and high blood pressures as negative predictors. And there's one report that also highlights the presence of crescents, which seems to be a theme also in other glomerular diseases like FSGS and other conditions, IgA, where the crescents are related to negative outcome. Again, very briefly, there's, as you probably know, a high risk for disease recurrence after transplantation. Reports, in part including children, vary in terms of numbers or percentages, between 1/3 and 2/3 of patients. Interestingly, in this one cohort, my pointer is not working at the moment, I'm sorry. Second to the last bullet point, in this French cohort with 35 C3G patients, there was some sort of a staged risk with the highest recurrence risk in patients with C3GN over dense deposit disease over MPGN. And in this British cohort at the bottom, in this English cohort, the very small numbers of 6 dense deposit disease patients out of 13 total all recurred. And overall, the risk of graft failure due to recurrence, again, is high. And that's summarized here at the bottom. I skipped this here since I mentioned it already, and finish off with this slide. Not to shock you, this is what you have heard now for 50 minutes. The complement pathway and its role in the pathogenesis of C3G. I want to use this slide since it highlights, where complement blockers are present and where they're expected to become available, and possibly then becoming beneficial for those C3G patients. So we have the eculizumab. We spoke of the very limited and not very convincing, by and large at least, kind of reports in terms of response. Those 2 red circles highlight a factor B and a factor D blocker by Novartis and Achillion/Alexion. This is certainly way closer, much closer to what we understand in terms of pathogenesis, and with that way more promising in terms of interfering with the C3 convertase activity. Also interesting is the Apellis product and Alnylam blocking C3. So one is a pegylated anti-C3 and the other one is an siRNA product, which is also much closer to what we understand in terms of mechanism. And then there's a couple of other products that may or may not really play a significant role, being a lectin pathway initiation inhibitor, Biomeros, and the chemocentrics avacopan at the right side, blocking the C5a receptor. I thank you for your attention and hope to at least answer a few questions. Thank you.
Thank you very much, Christoph. That was really excellent, and you have a ton of questions. So without further ado, I will start. I was trying to group them together, and actually 3 questions addressed the potential overlap between C3 glomerulopathy and post-infectious GN. So I wanted to ask you something about that. Essentially, Vaishali More asked, should one consider C3GN in recurrence of post-infectious GN? And Rajiv Sina asked, how can we differentiate between C3GN and infection-related GN? And Pedro Ortega asked, what about overlap between post-infectious GN and C3GN? And thanked you for a wonderful webinar. So I think that could be the first thing that you could comment on, please.
Right, and as it was scheduled, the next discussion, or the first discussion slide, is exactly on that topic. The infection-related or previously post-infectious glomerulonephritis. So we all know from clinical experience that there's patients who basically begin their journey with a signature that could fit with post-infectious GN or infection-related GN, or even C3G. And then those patients do not follow the typical recovery, take not the typical recovery steps after a couple months, but continue to be proteinuric, hypocomplementemic, and then are biopsied and might end up with a diagnosis of C3GN. So that was picked up by some colleagues, and Sanchisetti was pioneering, with this 2013 KI paper where he basically not only ended up with this concept at the bottom, but also sequenced his patients and identified a number of those in the subgroup of the post-infectious GNs as they were diagnosed with underlying complement defects. So, and his concept then was, while in the post-infectious or in the infection-related situation, it's a temporary disturbance of complement balance, and in the one that transitioned then into the atypical form and progressed to C3GN, it becomes permanent. So I don't think we have an answer how to basically predict with certainty, at the beginning. We have done an analysis of our own patients at the kids, and what we found is that the C3 levels in the true infection-related GNs was lower than in the C3G patients. So that was a hint that the degree of proteinuria was not the difference, nor was was renal function. It could have been impaired in both cases, but it was the degree of complement consumption in the very early phase, which was higher, and respectively C3 was lower in the infection-related situation. And then it was a clinical, it is a clinical observation, and eventually a biopsy next step that identifies then the C3G picture, which would then should then trigger the in-depth workup of the complement system, looking for both mutations or antibodies.
Great, thank you so much. So moving forward, we have a question from Hanna Flugilova that says, can a patient with SLE have a histological finding of C3GN?
Absolutely. We had patients who basically presented, lupus is a very complex, presentation, a very complex diagnosis, and obviously, this needs to be a patient needs to be evaluated looking into all systems, and we don't need to go into, basically the diagnostic criteria for lupus. If you are just looking at the biopsy, we had ourselves biopsy samples in whom we found a full house picture, or close to full house picture, that was at least temporarily suspicious or included in its differential lupus. Again, in the absence of, or ignoring for the moment, the rest of the diagnostic criteria, which would hopefully help to guide the establishing of the right diagnosis.
Okay, great. I'm again trying to group together some questions in the interest of time. There are a couple of questions on the renal biopsy. And Enrique Morales asks, what is your opinion on the role of interstitial fibrosis and tubular atrophy in the prognosis of C3G? And instead, Argyrios Georgalis asks, what is the significance of pronase treatment in biopsies with C3G phenotype?
Yeah, I will probably have to declare to not be the expert, on the pronase treatment for the biopsy. I know that this is, I recently discussed it with Pat Walker in the context of a book chapter development, and we kind of played it low, which is, pronase obviously serves to help antigen retrieval. It's I think a pathologist who really should answer the question about the specific significance in C3G. So I don't want to take a firm stand on that one. The chronic features of tubular interstitial involvement in C3G obviously are, from a prognostic point of view, if it is not, I mean, keep in mind those patients, I didn't mention that, but some of those patients are also treated with calcineurin inhibitors. So, if that was the background, of course, that should be considered, at least a tubular injury. But if you're talking about more an interstitial, progressive interstitial fibrotic picture, that would definitely be a negative predictive marker for, like the outcome of this patient's renal function.
Great, thank you so much, Christoph. So another question is Rajiv Sina asks if you can explain again how a mutation in the same protein can cause atypical HUS or C3G.
Yeah, again, the $1,000,000 question. So what I try to do is I try to highlight the subtle differences. So if let's go back to factor H. So and you can spell it out either through so it's the same protein that is involved either in this pathogenesis of atypical HUS, TMA, or C3G. What I tried to say was that in the situation of atypical HUS, the protein is typically mutant or impaired in its function via antibodies at its C-terminal end. What that does to the protein is it prevents it from attaching to a surface, and with that it cannot protect the vascular endothelium from complement attack. So that leads to a surface-bound overactivation of the complement system. Different from that, the mutations and the antibodies identified in factor H and related to C3G have the defects on the N-terminal, at the N-terminal end of the protein. That is where the function is governed. So the protein is there in normal amount. It can completely, perfectly well bind to surfaces. But what it cannot do is it cannot control complement activation. And that's how we, kind of put the puzzle pieces together and argue one diagnosis has to do with surface injury, the other diagnosis has to do with C3, unregulated, uncontrolled overshooting C3 activation.
Great, Christoph, that's really helpful. I have another whopper for you. Elsa Babaker asks, why do some patients develop DDD and others develop C3G?
Yeah, that's a killer. So if I was, more savvy with the history, how the diagnosis was established in literature, then and I would be in the shoes of some of the pathologists, they would single out dense deposit disease as a specific standalone diagnosis, and they would argue only basically by historical developments it was folded into the spectrum of this type 1, 2, 3 MPGN spectrum. They would argue it was really a membranoproliferative picture that kind of would connect to type 1 and 3, and the type 2 is an artificial addition to it. That's not really a good answer in the first place, but it is at least a historical hint that we may be in a situation where we try to make sense of something that in the first place doesn't belong to each other. That's at least some of what you might find in if you talk to a pathologist. The other argument remains, so I should have said the first answer is I don't know. The second answer is what I just said. The third answer is that it really might be the microenvironment that, in addition to the concept of this uncontrolled C3 overactivation and split product generation, leads then to the specific attack of either the specific deposition in the space around the basement membrane or within the basement membrane. But that's how far I can go. I don't want to pretend that I would be more confident to give you, to go further in detail.
Great, thank you so much. So I'm now going to try to put together, there's a variety of questions regarding treatment and management of these conditions. So to try to put them in logical order, the first one I would like to ask is from Statis Tsiakas, who asks you, which cases do you treat with immunosuppression?
Yeah, thank you for that. So maybe I should have been a bit more firm and have shown you also the flow diagram that I skipped for time. So the clinical sequence of managing, maybe I can even go back to it. The clinical sequence of managing a patient with an MPGN C3G pattern would be, after having established all the diagnostic details, is to support the patients by managing blood pressure and proteinuria and related issues, and basically allow for spontaneous recovery. That's step one. Step two for all patients at this point in time is immunosuppression, and then the intensity of immunosuppression using steroids and MMF depends on the degree of proteinuria and the degree of inflammation that you find in the patient. Moving forward, if we fail with this treatment approach, we could use what we have at hand today as specific complement blockers, but moving forward, we would hope to have real complement blockers that could be, that were being more specific and would allow us to be considered even, at an earlier stage of this therapeutic algorithm.
Great, Christoph, that actually answers quite a few of the other questions as well, so that's really, really helpful. Some people have asked, including Azmari Sultana and Shojiro Okamoto, if you have recommended dosing regimens, both for prednisone or prednisolone, and also for a recommended dose for MMF.
Yeah, so we typically would treat such a patient with our usual 60 milligrams per meter square with a maximum of 60 milligrams per day. And the treatment would be, but again, this can be argued and discussed, would be a daily treatment for 1 month. We would typically afterwards switch to an alternate day treatment for another 4 weeks, and then taper from there onwards. And then I think the duration of the taper is really a little bit of a flavor of the site, and also, of course, depending on the response of the patient. But you would cover with this tapering protocol the remainder of 6 to 12 months. I guess this is fair to say. For MMF, paying attention to clinical tolerability with respect especially to GI symptoms, we would build a patient slowly, but in the end of the day, try to achieve the 1100 per meter squared that we have, as a target in, for example, also a transplant patient.
Great, thank you so much. So moving forward with therapy again, Martine Bazell has asked, is there, in your opinion, a role for rituximab in C3G?
Yeah, very good question. So the rationale for the use of rituximab obviously comes from what I emphasized quite a bit, the role of autoantibodies. And I mentioned that you know, they're widely present. We're still struggling to really nail the, I think the mechanism we understand, but the relevance for pathogenesis, that's what we are still, you know, not 100% clear about. There is some literature on the, reporting the use of rituximab in this background with this rationale. So there is a rationale, but again, the literature is very thin, and the records are mixed, with some benefit, with some treatment success, and definitely a rationale. So if you had a patient in whom you felt, you know, that antibodies, you know, one or more, were identified and you didn't have any other cause, and there was an intention to target that, you know, this cause of the disease, possible cause for the disease, you had a rationale to use rituximab, yes.
Okay, now I'd like to give space to Enrique Morales, who asked, what is your opinion about the role of new complement blockers blocking factor B, factor D, or C3 and C3G, and connects to a question also brought forth by Graham Smith, who says that he tried to get a teenage patient of his into a trial of an oral C inhibitor, I think he means C5a inhibitor, a few years ago, but it was only recruiting patients aged 18 plus. Are there any trials of new drugs involving children?
Yeah. So thank you for that question. That's why I chose this busy slide at the end, since that's exactly the point that I wanted to make. So the red circles basically identify, especially the factor B inhibitor, LNP023, the Novartis product, will come out as a clinical trial recruiting from 12 years onwards. I'm not 100% sure about the situation in Europe, but that's at least for North America. And similar to that yellow circle or orange circle, the Apellis pegylated anti-C3 is also coming out within the next few months as a clinical trial, including adolescents 12 years and older, with international recruitment. And I'm painfully aware of the limitations of enrolling children into those treatment trials. You know, we're suffering from that same problem. But that I know firsthand, and I would encourage you to kind of, you know, make the respective connections to explore whether you could get your patients into those trials. I think this is promising drugs. I'm not advertising for any company here, but you know, from mechanism point of view and from what we have seen in terms of preliminary data with respect to drug efficacy, doing what it's meant to be doing, and also some preliminary data on in patients with C3G. In my mind, these are promising.
Okay, I'd just like to add to that, in the interest of sort of par condicio, that the avacopan trial, the oral C5a receptor 1 inhibitor, maybe not in the UK, but in other countries, both in Europe and in the US, has enrolled children 12 years and up. So those results are pending, but they will arrive. But within that study, already some children 12 years and up have been enrolled and treated.
It was unfortunately not in Canada, but you're right, in the US it was, they enrolled, yeah.
Yeah, so Parakal Vasudevan is asking you essentially for advice on a very difficult patient that was diagnosed 5 years ago with C3G. The child is now 14, did not respond to mycophenolic acid and steroids, and has now repeated a biopsy showing 60% glomerulosclerosis, significant interstitial fibrosis, and has in January 2021 a serum creatinine of 2.8 milligrams per deciliter. Now they do have access to import eculizumab. Do you think that it could be worth a try? And how would they monitor for efficacy?
Yeah. I mean, this is an unfortunate story. To be, I mean, hope dies last, but to be academically correct and you know, transparent, you know, with this degree of chronicity, you know, your chances to really see a breakthrough with a rescue strategy with a terminal complement blocker, I would say, are very slim. To be consistent with what I've said in the talk, as a rescue strategy, of course, you know, it would have its place, but I would have very low expectations to see a benefit, and then it becomes a risk-benefit ratio. I'm concerned that in a patient like this, you're too late, basically, to advance, you know, management in terms of rescuing the decline. Now, the one thing that I would probably do before I consider the use of eculizumab is I would, especially since you're mentioning, you know, I think you mentioned high degree of proteinuria. I would do MPA levels and maybe an AUC to see if you're, you know, dosing your drug in a way that you achieve levels that are meaningful. So, with other words, optimize your in quotes conservative immunosuppressive therapy as a first step. I have not mentioned, and again, I would not use it at this point, but it was on the slides that in very, let's say, aggressive forms of C3G presentations, steroid pulses, methylprednisolone pulses, you know, would be something to consider. But again, the risk-benefit ratio in a patient with this advanced degree of chronicity, I would be hesitant, I think, to engage there. Yeah.
Thanks, Christoph. Another very interesting question, and it's I think the last one we have is Jorge Rojas Rivera is asking, have the serum levels of C5b9 or the glomerular C5b9 deposits any value in the prognosis or in the therapy, in the therapeutic choice?
Yeah, so we have done, haven't published, but we have done for a defined period of time here at CKids, co-staining for in renal biopsies, all comers, but including C3G patients, you know, with antibodies against C3, C3C, and C5b9, and we have not found a difference in the staining pattern. And with that, we have dropped it. We were hoping to learn something. You know, looking at the difference between those two, kind of, you know, highlighting different steps of activation within the complement cascade, but we didn't find a difference. So I think the learning that you have through C3 staining, C3C staining is similar and will not be exceeded by C5b9 staining.
Thank you. Actually, there is one last question that arrived quite late in the day,
Sure.
but it really is the last one, I promise. So Dimitra Bakarachi is presenting a real case. A 25-year-old woman with nephrotic syndrome has MPGN on biopsy. Her father has membranous nephropathy. Could there be a hidden genetic complement mutation?
I say yes and check out. So could it be? Sure. Do I know of? Do I have any speculations? No. This is. I think this needs to. We would have to really see those biopsies and the cases in more detail to at least for me to give a smart comment on that. If your question is there a role for complement in both conditions? Answer is yes. And since it's a familial situation, is there a possibility, at least a theoretical possibility, that the two are connected genetically? I will have to say yes, but I cannot answer the next question, which is which one. Yeah.
Okay, well, listen, we're way over time, so I really wanted to thank you for being available for so long. I think this has been really fascinating. I'd like to thank, first of all, Christoph Licht for his time and for this absolutely fantastic talk, and I'd like to thank everybody for participating, and the slides will be available on the website for anyone who didn't have time to participate. Thank you very much to everybody. Bye-bye.
Thank you so much. Bye-bye, everybody.